Dr. Ayman, and thank you organizers for having me. This is the first time I've been asked to talk about this topic. So I'll try to keep it as simple as I can for pediatricians. Unless until you look, you're not going to see mastocytosis. Here I started my career in 2016, and by now 2020 I have a collection of 20 patients. Unfortunately, 19 of them are self-referrals. Only one patient was referred by the pediatrician. So unless until you look, you're not going to find it. So, I would like to thank my mentor, Fred Shea. So in the mastocytosis world, Mass General, they have started the research and they have started developing expertise, and they send to different places of the world their experts. So my mentor dedicated his life to one cell, mast cell, and he used to have a mast cell clinic 1 day a week. So throughout my career, during training, I spent time with him and also in his lab. And when I went to California, I became the regional guy for mastocytosis. And in UAE, a lot of the times patients find and come to me, or sometimes they're referred from out of countries. Yeah. So this is your typical mast cell. So this, in the allergy world, we call our allergy cell. It is a responder cell. We have huge amount of mast cells in every system of the body. So they are the responder cells. Whenever there's an allergic reaction, the mast cell get activated, and the activation can happen directly by irritants like opioids, painkiller medications, anesthetics, vancomycin, ciprofloxacin. So these kind of drugs can directly activate mast cell, or it can get activated during an anaphylactic reaction by the complement cascade, or by the typical allergic antibody response. So this is an effector cell during allergic responses. So mastocytosis is a disorder characterized by clinical symptoms, neoplastic proliferation of mast cells in one or the more other organs. They have significant pathological distinctive features, and mast cell hyperplasia is seen in different organ systems, and a frequent association of this hyperplasia is seen in the end spectrum of the disease with associated hematological abnormalities or hematological malignancies. And clinical features are multisystemic. I'll explain more in detail as we go forward. This is a typical mast cell biology. So the human mast cell is developed in the bone marrow. So it has CD34 and CD117 or KIT. So this is a receptor for stem cell, so stem cell factor or SCF. So during the maturation, the CD34 is downregulated and CD117 or KIT receptor is upregulated. And on the CD117, the stem cell factor acts and the mast cell will become mature and will come out of the bone marrow and go to the tissue. The mature mast cells have a lot of cytoplasmic granules, and there are so many mediators, prostaglandins, leukotriene, tryptase, the main mediator, histamine, and it is quite stable, and it has a FC receptor, and there is IgE, which you make in the body, is bound to this receptor. Whenever you're developing allergy to anything, the specific IgE will bind to that receptor and will cause activation of mast cell. Or there are direct receptors which I mentioned for complement or medications. These mast cells are found in various tissues. Huge density in the skin, in the mucosa, in the gastrointestinal tract, respiratory tract, lymphoid tissues. And they're normally not in very high amount in circulation. So we don't have the ability to measure serum mast cells. Usually in the tissue, they are long-lived. They live there for longest period of time. If you look at on comparison with granulocytes, which the max, the tissue-anchored granulocyte like eosinophil can have a 2 to 4 week half-life, but mast cell has for many months. If you look at the etiopathogenesis of mastocytosis, so the etiopathogenesis of mastocytosis, which is abnormal proliferation and mediator release and systemic symptoms and organ presence, occurs most often at a specific exon, at exon 17, we call it as D816, where one amino acid is replaced by the other. D816, the V is replaced by A, and that causes abnormal proliferation of the mast cells. And this is because of the mutation in the c-KIT. Okay. And if I can, if you see at the 17 location, I'm sorry. I think it's a laser pointer. So at the 816, exon, at the 17 location is where the mutation, but others are also there. They're not that common. So one other thing will happen is this abnormally proliferating mast cell is supposed to be cleared, right, by various mechanisms, but they have anti-apoptotic proteins like BCL2 and BCLXL. That way, the neoplastic proliferating cell, it survives long in the tissues. And some patients will have a FAP1-like platelet-derived growth factor mutation, and the prognosis is usually poor if this mutation is found, because these neoplastic cells are very resistant to clearance by immune system. Sometimes they are resistant to the chemotherapeutic agents as well. And the disease is usually severe. Tryptase level is elevated in these patients. Pathogenesis. The pathogenic changes, the KIT mutation is happening and the cells are abnormally proliferating. They go and reside in various tissues, predominantly skin mucosa, respiratory, gastrointestinal tract, and other tissues as well. And these cells are so fragile, they start releasing their mediators. And these mediators will cause the systemic symptoms. And they can also go to the lymphoid tissue, liver, spleen, and sometimes bone marrow infiltration. Sometimes they can have associated hematological malignancies. And these are various mediators which cause various symptoms. In the interest of time, I'll move fast on this. What are the end organ effects of mastocytosis? So in the skin, we see Urticaria pigmentosa and maculopapular cutaneous mastocytoma, a diffuse cutaneous mastocytosis, and solitary mastocytoma. I'll just show you the picture so that you understand. Here in Mediclinic City Hospital, I have a collection of 10 children with cutaneous mast cell lesions. So Urticaria pigmentosa, it is the most common skin manifestation. If someone has to get mastocytosis, the best one I want them to have is this Urticaria pigmentosa, because these lesions involve only skin, are very, very dormant, stable. There's no mediator release. There are no systemic features. There's no lymphoid or bone marrow involvement, and there are no systemic symptoms as well. So oftentimes they spare the palms and soles, face and scalp that are present. And one interesting thing is, it is oftentimes even missed by the dermatologist because it looks like a small hyperpigmented brownish macule. They can call it, oh, this is an actinitic solar keratosis we are seeing. This is some non-specific dermatitis. But you guys can do a simple test. Just rub on it. What will happen is it will grow. The brown lesion will have like a halo redness erythema around it. This is called as Dreyer sign. You can repeat n number of times in any of the brownish macules you're seeing. And in Urticaria pigmentosa, this is consistently going to be positive. It's a simple clinical test which clinches the diagnosis. And the sensitivity or specificity of the Dreyer sign in terms of Urticaria pigmentosa is more than 90%. Even before the biopsy, it makes you think, okay, this is what I'm looking at. When the brownish lesions are there and on rubbing, they're giving a erythematous halo, which is the Dreyer sign, that usually is very consistent with Urticaria pigmentosa lesions. And oftentimes these lesions, as these are abnormally proliferating mast cell and histamine leak can be there, pruritus is there. Okay, and these lesions can be activated by various things which are usual triggers of the mast cells. This is a typical picture you're seeing. See how brownish macules are there. Sometimes they can be mislabeled as, oh, this we are seeing an early acne, or this is something like actinitic keratosis. And you see, they can be plaque-like, they can be rose nodules, they can be called as different nodular lesions. All you need to do is rub those lesions, and they'll develop beautiful redness around them. And this is Urticaria pigmentosa in an adult, okay? Yeah, diffuse cutaneous mastocytoma, not that common, okay, but a few patients I've seen in my career. It's extremely rare form, okay, and diffuse mast cell infiltration is there, and the onset is very early, and skin is normal to yellowish brown, and may exhibit discoloration, and spontaneous resolution occurs very early, okay. So surprisingly quite extensive distribution, but spontaneous resolution. That's why we don't see this often. Most of the times, they are self-resolving. But whereas the UP lesions will be persistent for a long period of time, very few percentage of children with UP will progress into indolent or systemic mastocytosis. Solitary mastocytoma, its presence in the first 3 months of life, it's again plaque or nodules and usually located on the extremities. They spare the palms and soles. And again, these are also spontaneously resolving. So the only thing which we see in clinics is the UP lesions. Rest of it is going to resolve faster. Telangiectasia macularis eruptiva persistens. This is kind of rarely seen in adults. I have seen 2 cases in my lifetime. Okay. And it usually coexists with Urticaria pigmentosa. So this is Urticaria pigmentosa. If it progresses into adult life, it may be seen. Gastrointestinal manifestations are very common with systemic mastocytosis. They present with myriad features. When the mast cell is releasing histamine, tryptase, prostaglandins, leukotrienes, so many things can happen. Non-specific abdominal pain, cramping pain, excessive acid production, dyspepsia-like features, and peptic ulcer disease is also seen. And oftentimes, the clinching thing here is the gastroenterologist will do endoscopy and biopsy, and he'll say, oh, there are histopathologists will report excessive number of mast cells are seen, okay? Because normal mast cells are already present in the gastrointestinal tract. And they're excessive in number, that's when I come in and have a look at them, yeah. And then unfortunately, we have to redo it because there are special stains required. The regular HND won't pick it up. So we redo the endoscopy and biopsy and get the staining, get the KIT mutation analysis, and get the tryptase level and confirm that this is mastocytosis. Musculoskeletal are also very common. Some of the mediators will cause osteoporosis. So musculoskeletal features are very common. Fractures are also very common in the adult. I have 2 patients here, adults, who presented with fractures and later on found to have mastocytosis and very severe osteopenia and osteoporosis. One I manage with my rheumatologist and one with our orthopedician. Bone marrow biopsy is the clinching for diagnosis for mastocytosis. So as I told you, it can involve the bone marrow as well. In the bone marrow involvement form of mastocytosis, you have 2 forms. You have indolent mastocytosis. That means these are abnormal mast cells. They're just residing in the bone marrow. They're not doing any harm. And the other thing is the smoldering mastocytosis. That is, they're present in the bone marrow and have mediator release and systemic manifestations. And the other forms are associated hematological malignancies or aggressive mastocytosis, where it is present in all the organs and causing the damage. And bone marrow biopsy, there are certain very specific things to be done for identifying the mastocytosis. So I use our esteemed colleague, Dr. Mohammed Marashi, for biopsy, and I send the request very specifically. They have to be done in that sequence to identify. They have to do immunohistochemical staining for tryptase, otherwise they'll miss it, which they don't do in routine bone marrow biopsies. They have to do the KIT mutation analysis, which I request on the bone marrow biopsy, and they have to count the number of spindle-shaped mast cell aggregates in 2 or 3 locations and tell me if it's 30 or more, and per high power field if it's more than 15, if it's extracutaneous. So all these things, and also the flow cytometry has to be done on the cells to see if CD2 and CD117 are high or not. So these are all important for diagnostic criteria. So the bone marrow biopsy, whenever it's done, we have to send specific requests. Yeah. A lot of the times by the patients come to me and they have a bone marrow biopsy, which doesn't give me any information. And if the clinical suspicion is high, I may ask to repeat it with giving specific instructions on what I want. And this is a typical bone marrow biopsy. Hepatic and splenic involvement is also very common. Lymph nodes can also be involved. Most common location in the paracortical region. If you do the tryptase staining, you may find the mast cells. And this one patient I picked up here by headache. I've seen everyone, has gone to neurologist, just has intractable headache, severe atopic manifestations, adult patient, has some skin lesions, hepatosplenomegaly, has seen hematologist, has some eosinophilia. Unfortunately, patient had very aggressive systemic mastocytosis. To send her back to home country for BMT, for cytoreductive therapy. Clinical manifestations, it's the mediators which cause the symptoms. Constitutional symptoms, skin symptoms, mast cell mediator related symptoms, and musculoskeletal symptoms. The mediators cause symptoms in various systems, especially gastrointestinal tract, respiratory tract, and also on the skin and also on the musculoskeletal. In addition, constitutional symptoms may be there. B and C we discuss as we go forward. Skin, GI tract, lymph node, liver, spleen, bone marrow, musculoskeletal are very common. Reproductive, endocrine, and drainage systems are often spared. There are not that number of mast cells residing in this. There are no chemotactic factors which make the mast cells go. So these systems are often spared. Patient in every category of mastocytosis may sometimes experience flushing or episodic hypotension whenever they are having hot and spicy food or alcoholic beverages or non-steroidal anti-inflammatory drugs. They have episodic flushing, and if you look at the episodic flushing differential diagnosis, mastocytosis is one of them. Occasionally, hypotension can be, same things can evoke the hypotensive response as well, because massive histamine is going to vasodilate and you're going to feel transient hypotension and your cardiovascular reflexes will bring it back. Clinical features, I think again I highlighted: cutaneous, systemic, cardiovascular, pulmonary, gastrointestinal, musculoskeletal, and neurological. Renal is never involved. Endocrine is very, very rare to get involved. Classification, I'll keep it very simple. Cutaneous mastocytosis, 80 to 90% of the time it stays cutaneous, doesn't progress. And sometimes it progresses into systemic. So there's always an assessment is when to consider. How many times can I do a bone marrow biopsy in a child? So when to consider bone marrow biopsy? So we do periodic assessment. We make sure of, are there any symptoms and signs of systemic involvement? Are there any other features like hepatosplenomegaly or lymph node enlargements? And that is the time when we consider, but otherwise we monitor these patients with markers of mediator release. And systemic mastocytosis, one extracutaneous organ is involved with or without of evidence of skin involvement. This is the WHO classification: cutaneous, UP, other two are self-resolving, indolent systemic. Skin may be involved, but they're very stable in the bone marrow. They don't cause any problem or any mischief. Smoldering, they're in the bone marrow, but they're having systemic features as well. And systemic mastocytosis with hematological abnormalities, aggressive systemic, and leukemias and sarcomas. Yeah. So these are the type B findings. There is increased mast cell burden, dysplasia, organomegaly, and then type C findings, which you are going to see serologically. So indolent systemic mastocytosis involves skin and bone marrow. Most common form of systemic mastocytosis. Smoldering, so there are B findings and there are no C findings, mainly affects older individuals or adults, and oftentimes constitutional symptoms are there. This is associated hematological malignancies. Aggressive, I lost 2 patients with aggressive systemic mastocytosis in California. Quite aggressive organ dysfunction. And the other thing is they are all often associated with MCL, mast cell cutaneous leukemia. Yeah, mast cell leukemia is very rare, quite aggressive disease. Patients are adults. Cutaneous lesions are not there. Systemic features are present. By the time they come to us, it's too late. And they need cytoreductive therapies, chemotherapies. And if along with this, the FAP1 gene mutation is positive, their response to therapy is not that much. Usually prognosis is quite poor, less than a year. Diagnostic criteria. So this is a WHO diagnostic criteria universally. So cutaneous mastocytosis, it's cutaneous lesions and histopathological confirmation. And systemic mastocytosis, the major criteria is you have to do bone marrow biopsy and you have to demonstrate that more than 15 mast cells per hypor field are present with tryptase positive. And minor criteria, 25% of spindle aggregates, KIT mutation positive, CD2, CD117 positive, and serum tryptase elevated than 20 nanograms per ml. And usually for diagnosing systemic mastocytosis, you need 1 major, 1 minor, or 3 minor criteria. And if they don't fit into this group, we call it as mast cell activation syndrome, where they have any 1 criteria present and they are seeing us. Diagnostic approach. So unexplained ulcer or malabsorption, radiographic evolution on the bone scans, and hepatosplenomegaly, lymphadenopathy, peripheral blood abnormalities, unexplained flushing or anaphylaxis. Sometimes we find patients having excessive anaphylactic reactions and no cause. So we call them as idiopathic anaphylaxis and sometimes the flushing episode. So we pick patients from that. Otherwise, very tough disease to identify. Only way or clinically sometimes it's evident to us is excessive atopic manifestations, multiple drug hypersensitivity, anaphylaxis. This is a clinical picture and multi-system involvement. If you're seeing in the clinics, basic thing is look for UP lesions, check serum tryptase. These are very easy to do. And if your suspicion is high, and don't rely on tryptase. Tryptase may not be elevated in all the forms of mastocytosis. If you find very high, then the diagnosis is then and there itself confirmed. I do the staging. If not, then send to us for bone marrow biopsy or more specific diagnosis. Investigation, skin and bone marrow, I mentioned already. Serum tryptase is often, is one of the minor criteria, and cutaneous and indolent may not be elevated. Okay, higher the tryptase, more the burden, so more organ involvement and more systemic features. And tryptase can be elevated without mastocytosis in mast cell leukemia, and chronic myeloid leukemia, and myelodysplasia as well. And genetic markers, I do the FIP1 gene as well, and this is the WHO criteria in terms of where we put, is it cutaneous, is it systemic, if in the systemic, is it indolent, or is it systemic smoldering, or is it aggressive or leukemia. This is the algorithm. Treatment, I'll keep it very simple. Counseling, manage, I'll go over this. So these are the things which we do, but this slide is very interesting. So it gives you everything. So no symptoms, we follow up. And site-specific symptoms are mediator release. I use H1 blocker, H2 blocker, leukotriene receptor antagonist. If there's a severe acid pepsid disease, I take the help of the gastroenterologist. And, if it's kind of smoldering or aggressive and systemic, then we go for cytoreductive therapies. And we sometimes may need the tyrosine kinase inhibitors, and last is the bone marrow transplant. Bone marrow transplant, treatment option for patients with advanced categories, often associated with poor survival, may yield better prognosis with mast cell suppression attempted prior to transplant. Prognostic markers, patients with cutaneous mastocytosis have best prognosis. For children with isolated UP, reported as 50, but 80% they stay as UP and don't progress. Some UP in adult life may become systemic. Occasionally, ISM convert into smoldering, like indolent becomes aggressive as well. So we need monitoring of these patients. Thank you.